Hi, Dr. Garima here, and we are solving another scenario of the Australian Dental Council exam, written exam paper provided by ADC to show you all how the actual exam paper looks like. So let's right away jump into clinical scenario 22. Andrew's parents are requesting a second opinion specifically regarding treatment of the space between Andrew's front teeth. The regular dentist told them that the space between Andrew's front teeth cannot be closed without a frenectomy. Andrew is 10-year-old and his upper permanent canines and second permanent premolars are yet to erupt. Very good question this is. Most of the dental graduates, especially the recent passed out, because your orthodontic exposure is so less, which includes the interceptive orthodontic exposure, even in the clinical scenario or in the pedoclinical postings, many times you people just fail to address very common malocclusions that are self-correcting, or you all don't know. And I'm not blaming you at all. Even when I was at that stage of internship, even I have missed so many cases that could have been corrected very nicely using interceptive orthodontic techniques. Because of the very reason that in the orthodontic postings, all they used to tell us was to deliver Hawley's appliance or just diagnose class 1, class 2, class 3 malocclusions. Nobody ever insisted to check the frenum properly or the posterior cross bites or many other issues like this where there were diastemas, at what age, what treatment options could be given. Nothing. And orthodontic postings for me were basically giving the attendance and sitting and just delivering Hawley's appliance. And there were barely any OPDs actually. Most of the PGs used to take the case and they were in the fixed ortho, and you never did fixed ortho as a dental graduate, right? So I think one of the subjects which was like just brushed upon or touched for the sake of it was orthodontics. But as a general practitioner, there is still so much you can do, in that field. But anyways, even if you don't have the expertise or the skills to start any treatment, you can at least diagnose it properly and give a correct advice. That much you can do instead of just telling the patient, you know what, come on so and so day, I'll call my orthodontist and let him have a look at it. Why don't you have a look at it? Why don't you diagnose it? And then tell the orthodontist, this is the problem I feel and what is your take on it? Instead of just blindly referring. So I understand this will only come with practice, but there are so many good orthodontic videos, interceptive ones, which you can go through in your free time, and they're really interesting. I myself have made a couple or so, and I wish to make more. It's just that time. But now that my son will turn 4 in the coming January, I am naming that year as year of focus. I'll go back to my disciplined days before he was born, because now, by God's grace, he's like, I would say 80% independent. He doesn't have to really stick to me for small things. He can manage it himself. So I'm not over exhausted now, which I was, because it was a single parent thing, okay? I mean, I have a husband, but he's busy with his work, honestly. So it's basically a single parenting going on my side. So it was really exhausting managing clinic, home, my son, and ADC and various other things that I do. So I eventually got overwhelmed, I guess. So this December month, I'll be just chilling a little bit, recovering, and 2026 is the year of focus where I'll, form my schedules and plan to stick to it and get a lot of things done, which I do want to. So anyways, let's go back. I'm just grateful and blessed for whatever it is. Yes. So you will see such cases pretty often, the picture that is given here, and many of the times wrong advice is being given to the parents, because I'm not saying they're deliberately doing it, the general practitioners, but probably they don't know that much information. But I'll give you basic things out here, because this is a very pretty common scenario. In fact, the day before yesterday, I had a patient, a French national, with the same condition, and the mother was concerned, "Doctor, how the gap will close?" And I was like, "Just relax, let the canines erupt, and then we'll decide." Never guarantee that it will close when the canines will erupt, the permanent canines. You do understand Broadbent's phenomenon, right? The ugly duckling stage. I literally opened my YouTube and I showed her the animated video of ugly duckling stage as to when the canines come, how the diastema happens in the front teeth, especially between the age of 8 to 10 years. Because the canines are descending. They start coming at an angle from here, and they come down and they put pressure on the roots of the laterals, which in turn puts pressure on the roots of the centrals, and the teeth go, the crown of the teeth go flying out, while the roots are completely, interproximated with each other. And once the canine descends down, it kind of self-corrects and the diastema closes. So you don't know this diastema could be because of the canines descending. It's always good to take OPG. But many a times, a supernumerary tooth is also present, which is the cause of a diastema. So first thing you should do always is to rule out a supernumerary tooth. If there is no possibility of taking an OPG, you should first take a periapical radiograph. A periapical radiograph will easily give you the best knowledge about whether there is a supernumerary tooth or not. If there is no supernumerary tooth present, just chill. Tell the patient, come back. Like for regular checkups every 6 months, but for this, come back when the permanent canines have erupted. Usually between the age of 12 and 13, and then if the diastema has not self-closed, then you can think of a fixed ortho treatment and do it. Another important tip I would give you is that check if there is diastema with parents, So many times it's hereditary, it's just present, like no matter what. And sometimes some people like it because it runs in their family. It's kind of their distinguishing characteristic feature, So check with the parents. If mother or father has it, then you can tell them maybe it's hereditary, you never know. And if you don't wish to have it, we can of course close it. So you'll get an idea at that point of time. So many times, I have seen skeletal malocclusions in children which I detect one of the parent is having it. Especially the posterior crossbites, I will check there is a right side or a left side crossbite, and then I look at the parents and I'm like, do you all have a crossbite? And one of them says, yes, I have, or my grandmother has, specifically class 3, it is so running in the family. And then the patient gets even more convinced to treat it because they're like, yes, we see them suffering because of it, So at least if you diagnose it properly, and even if you're not treating, and tell them, okay, you know what, this is the cause and this is how it's going to lead into the consequences, then the patient will be even more convinced to continue the ortho treatment in your clinic by an orthodontist, because you actually gave time in making them aware. And now that they are aware, it becomes very easier for the orthodontist to do it. When I started treating interceptive ortho patients, wow. It was a very fulfilling experience in itself, because so many earlier skeletal issues you could just correct within few months, and then the child keeps growing, the bone keeps modifying, and it just stabilizes so beautifully like nothing ever happened, So doing interceptive ortho treatment at the right age brings wonders, literally wonders. So anyways, going back to the question, so because his permanent canines and premolars are not erupted yet, you're pretty much going to tell parents to relax, wait and watch until they come, and then we'll decide about the diastema. Now here the question is also mentioning second permanent premolars, okay? Why? We'll see that. Andrew's anterior label frenum upper blanches the interproximal papilla, because this is a very thick attachment. There are 4 classifications of label attachment. Ideally, the frenum should be attached only till here. If it's going down or it's deep and it's blanching this area, it means it will keep pulling the gingiva, the attached gingiva, which it is not supposed to do. and then it will keep causing diastema, or this is trauma of the frenum, and there would be recession happening in the long run, you know. So obviously, even if there was no diastema and if there was a thick penetrating type of a frenum causing blanching of the interproximal gingiva, you should still get a frenectomy done. What additional investigation should you do to identify the cause of Andrew's problem? So you may think it's because of this frenum, but you just want to rule out what? The supernumerary tooth, right? How will you do that? Take a periapical radiograph. They have not mentioned OPG here, otherwise that would have been my first choice, because they are sometimes inverted mesodents, you know, which is difficult to detect on the periapical radiograph if they are high up. I would have actually chosen an occlusal radiograph, but here the answer mentions a periapical radiograph, which is not wrong. You can just take it as a basic radiograph, and if you find you know, you need a little more picture, then you can jump onto the occlusal radiograph. My personal preference would have been OPG. It would have clarified a lot of other things as well, because it would have shown me the second premolars also as to what is happening, because the question mentioned the second premolars have not erupted. But here they have not given the option of OPG. They have just said MRI, which I will not do. Periodontal probing is not going to give me anything. A lateral cephalogram, not needed right now. So if you were to be confused, A and B would have been the option. So going with option A is not a bad option. You know, you can choose option A. But if option of OPG was present, I would have say hands down go for it, because the question mentions second permanent premolars have not erupted. So you might as want to check what is happening with that. Okay. Andrew's parents are anxious to avoid unnecessary surgery and ask if there is effective alternatives to frenectomy. Okay. Now, based on the clinical picture, what evidence-based advice you should provide? Normal growth will not close the space between Andrew's front teeth. That's wrong advice. Normal growth is likely to close the space between Andrew's front teeth. Like I said, do not guarantee, because it's not necessary. Even after the descent of the canine, the space will close. A minute diastema can still remain, you know. So do not kind of promise. Frenectomy is unavoidable if the space between Andrew's front teeth is to be closed. No, it's not like that. Frenectomy is avoidable if the space between Andrew's front teeth is closed orthodontically. Now, this is a very good option. See, frenum is like a physical obstruction. Okay, even if you forcefully close the gap between the two front teeth and don't do frenectomy, it's gonna open up again, because it's not a stable closure. It's a forced closure, and it won't be retentive if something is constantly pulling or there is a constant physical obstruction in the form of gingiva. You have to get rid of it. Wait until Andrew's canine teeth erupt and reassess the need of frenectomy. Now, this is a very correct option. Now, you might debate then what is the difference between option E and option B. Both are kind of normal growth, you know. But in normal growth, there is no deadline that you have given. Like, when would you assess? When would you think normal growth would be over? Option E becomes more specific. That wait for the normal growth until the canines erupt. If the canines have erupted and then also the frenum, then also the diastema has not been closed, then you can assess the need for frenectomy or not. So you're giving some kind of limitation to the timeline. In option B, there is no limitation to the timeline, so you cannot wait indefinitely. You understand, for the normal growth. So option E is the correct answer here. To support informed consent from Andrew's parents, you include in the discussion a possible treatment option of combining frenectomy and orthodontic treatment. Okay. For this treatment option, why should you recommend early frenectomy in combination with orthodontic treatment? Okay. You tell them that, you know, when the child is around, say, 13 and the canines have erupted, and you would be going ahead with the orthodontic treatment, you can do frenectomy at that point of time. But you also are choosing to recommend early frenectomy, like basically do frenectomy and then start the orthodontic treatment, not like finish orthodontic treatment and then do frenectomy. Okay, so why are you recommending that? Frenal attachments are an impediment to orthodontic closure of diastema. No, they are not impediments, but they will definitely cause relapse if not removed. So you can forcefully close, but then you won't be able to retain it if once you remove the fixed appliance. So they are not impediments, but they definitely will cause relapse. A frenectomy will avoid the requirement for a retainer. No, it does not. Frenectomy is working in the front dimension. Retainer still has to be given because they are palatal gingival fibers as well, and the gingival fibers, the periodontal fibers, have a memory quite long time. I think somewhere I read it was like 1.5 years or something. So no, retainer would still need to be given. Frenectomy facilitates interproximal tooth cleaning during orthodontic treatment. It can, but it's not like if you don't do, you can't clean, you know. Orthodontic tooth movement is less likely to be impeded by scar tissue. Yeah, this is like theoretically it says that once you finish frenectomy and then you do ortho treatment, then because there is no scar tissue, because it's healed well, your treatment will go more smoother, effective, faster, and efficient. I have personally not found anything like this. I've seen many orthodontists finishing the treatment and then do frenectomy. Okay. So if you want to go by theory, then you can choose option D. Frenectomy will address the soft tissue aesthetics. Yes, it will, but that is not why you are doing frenectomy out here. So out of all the options, textbook option is option D. But I'm telling you all, clinical practice, it doesn't work that way sometimes. You just finish ortho and then you do frenectomy. You know. For adult patients. For children, yes. I do frenectomy before because it's just easier for me to settle into ortho after that, you know. So I prefer doing frenectomy just for the convenience purpose, and that I don't have to do any surgery once the treatment is done. But in adult orthodontics, people usually, you know, do the ortho first and then do frenectomies. 2 more questions. Andrew had his diastema managed by an overseas orthodontic practice. Okay, he went elsewhere, he went out of Australia, finished his ortho, returns to you as an adult. He was 10 when he visited you. He's visiting you now as an adult, say probably he's 18 plus. And he's still concerned that he has gaps for the back in the mouth. He has not seen a dentist for 5 years. You take a clinical photograph and radiograph. Which of the following best describes Andrew's condition? Okay. Now this is a very nice OBG. You see the molars. These are milk molars. You can make out by the roots that this is not a premolar. And they are stuck. There is no gap. As in there is no space, enough space I would say. I wouldn't say no space. There is not enough space for these teeth to erupt. There is mesially tilting of the molars, further reducing the space. And most importantly, these teeth are ankylosed. They are infrabulged and they are infracluded. That's the right term. They are infracluded and ankylosed. Now, if the orthodontist knew about this and then it was the patient's decision to not extract this teeth and finish ortho as it is, ideally the space should have been maintained by putting blobs of cement on them if the patient did not desire to extract such teeth and put an implant later on in life. Or orthodontically the space should have been maintained, you know, and given a space maintainer or something after the ortho treatment was finished. But somehow the molars are tilted, the bite is screwed, I feel. But most important thing is that the patient has submerged deciduous second molars. Okay, and it's again a very common condition which I see in a lot of children nowadays. So what I do is, if the parents are okay, I send them to the oral surgeon and get them extracted, and then we close the gap orthodontically, or we maintain the space for future implant. But I don't keep them in the mouth because they will invariably cause tilting of the posterior teeth, which will complicate, you know, things. So you see how this has tilted. the entire occlusion gets screwed up. Now you cannot classify this as a class 1 occlusion. You'll say this is class 3, but the canines are in class 1. So anyways, and yeah, this is like real sad as supra eruption of teeth happens, of the others. So anyways, this is the clinical picture and this is the radiographic. So what is the problem here? Which of the following condition describes best? It is ankylosis of the deciduous second molars. That's the straightforward answers. Don't even think anything about it. Now Andrew is upset that the reason, now this comes in the professional ethical category. Andrew is upset that the reason for the posterior gaps was not diagnosed or managed by the overseas orthodontist, which I think is very unlikely, I think Andrew is just making it up that it wasn't diagnosed. It cannot be that the dentist has not informed the patient that you have submerged second molars. But anyways, you have to believe the patient. His parents would like to know to whom they should complain. He's an adult now. Andrew is an adult now. And still the parents want to complain. What professional advice should you give to the parents? See, never, ever, 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 ever trust patients' words. Take it from me. A decade more of practice now, and take it from me. Never, ever trust the patient's words, okay? You will show them that you believe them. They can be right, but they cannot be 100% right. They will likely put the blame entirely on the dentist. And I'm not saying because we belong to the same profession, but when you have not seen what kind of communication the other dentist has made to this patient, you cannot just put a blame on him or incite or instigate the patient to go against the dentist. That is horribly wrong. You should have professional integrity. You could have been that overseas dentist, You could have been that orthodontist who treated that patient and gave him full information, and yet the patient could have gone and complained against you. Then what would you like? The other dentist inciting the patient against you? No. So the best option is to ask the patient to go back to the previous dentist and ask about his concerns. Sort it out between two of them. Okay. If not, if this option is not given, then you can tell the patient that request a copy of the dental records from the previous dentist, and then you can go through them and then see what the dentist has written. And that is where documentation becomes so important. Make sure to write each and every detail. I know it takes time, sometimes when I have back-to-back patients, I just write one-line notes, and once I'm done with the patients, and no matter how much tired I am, I sit and write in detail about each and every patient, because documentation is so important. You would never remember what communication you had with a particular patient on a particular day if you are a busy practitioner. You won't remember which patient you saw last week. You'll have to open your notes. So when you open and you have written in detail, it makes you remember. If you are no longer existing due to some reason, that patient goes under the care of some other dentist, it is helpful for the other dentist also to know what has been done and how the patient is, So documentation of notes is very important. So here, let's see the options. What professional advice should you give the parents? Forget all about it, as it involves an overseas clinician. No, that is not an advice you will give. Write to the treating clinician detailing his complaint. Okay. You will tell the parents that they can write to the clinician about his complaint. You are not writing, you're telling the parents to write, okay? Write to the registering body in the country where he was treated detailing his complaint. No, you're not instigating the patient to go against the dentist to his authority. Write a letter to the editor of the national newspaper. Wow, I'm going to stop right there. No, you're not going to do anything like that. Promulgate evidence of his poor treatment to potential patients via social media. Wow. No, this is horrible. This is criminal act. No, you should not do that. The most professional thing to do is to ask the patient to write to the dentist and let the dentist give an explanation. Maybe the dentist will tell him, you know what, I told you everything about it. This is the consent form. And the patient will realize, oh yeah, he did mention to us about that. Yesterday only, you know what, I had a patient, a 10-year-old. She had visited another clinic in Dubai, and she had the OPG on her phone, and she had come with the concern that there is a small pit cavity, basically, in their words, on the back of the lateral incisor on the upper left side, okay, tooth number 22 basically. I checked the OPG, and immediately I saw there was dens invaginatus, you know, that typical appearance of tooth folded within itself. And I was like, she's having dens invaginatus. And then I checked her clinically, I took pictures, I showed to the parents, and I was like, you visited the other dentist, and were you explained about this? The mother was like, no. The father had also come. So I was like, this is strange, because the OPG clearly shows. But anyways, you know, like, what can I say? I don't want to say anything about the dentist, I wasn't there. So I told them that, listen, it's a small pit, but it has a deep canal kind of communication in the tooth, and the best option right now, because there is no pain, there is no infection, let's seal that up. And we hope that nothing happens in future, because you don't want to go drilling way inside, you might just expose the nerve. So when I explained all this properly, and they were Chinese nationality, so I usually Google Translate to explain them. At the end of my appointment, okay, after doing all this consultation, the father says, oh yeah, about this we were told by the other dentist. You see, so the first reaction of the mother was like, no, we were not explained, and that's why we wanted a second opinion as to what this is, because we were brushing very nicely, so how did she end up with a cavity? So I told them, it's not your fault, the tooth is anatomically like this. So at the end of all this, the father said, yeah, the dentist did mention about dens invaginatus. So you see, you never know what the patient might say, and how much they remember, or how much they would act as if nothing has been explained to them. So all these things you should document, right? So anyways, I hope this was good, and looking forward to your comments. And yes, of course, you should go through this book, Ultimate ADC Written Companion, where there's 1400 plus scenario based questions from the ADC resources, basically the question bank of ADC. And I can send you a sample of this book if you can email me. And the second book is Comprehensive ADC book, which has therapeutic guidelines, infection control, ethics, consent, all the questions. Again, there are 400 plus questions with explanations and answers. So yeah, again, happy to send you all this book, a sample copy, if you email me. And have a nice day. Bye bye.